a relationship or changing job, death of a loved one, developing a serious illness, developing a serious illness, being a victim of crime, having an accident, undergoing a major life change, example, getting married or having a baby, or living through a disaster. Then stressors for children and adolescents can be divorce or separation of parents, family conflicts, moving to a new place, for example, joining a new school, birth of a sibling, illness of either the child or a loved one, loss of a pet, problems in school, sexuality issues, as we see in adolescents. Now let us come to the diagnostic criteria as per the DSM-5, ICD-10 and ICD-11. So according to DSM-5, adjustment criteria has the following diagnostic criteria. That is, development of emotional or behavioral symptoms in response to an identifiable stressor occurring within 3 months of the onset of stressor. Now, 3 months here is important, as in ICD-11, we'll see it is 1 month. So the symptoms should develop within 3 months of the onset of the stressor. Now, these symptoms or behaviors are clinically significant as evidenced by one or both of the following. Either there is marked distress that is out of proportion to the severity or intensity of the stressor, taking into account the external context and the cultural factors that might influence the symptom severity and presentation, or there is a significant impairment in social, occupational, or other important areas of functioning. Now, in ICD-11, we'll see this also has certain changes. Now, the stress-related disturbance does not meet the criteria for any other mental disorder and is not merely an exacerbation of a pre-existing mental disorder. That is why we said earlier that it is also known as a wastebasket diagnosis. Now, the symptoms do not represent normal bereavement, and once the stressor or its consequences have terminated, the symptoms do not persist for an additional of 6 months. Now, according to DSM-5, there are certain sub-specifiers as well, which include with depressed mood, with anxiety, with mixed anxiety and depressed mood, with disturbance of conduct, with mixed disturbance of emotions and conduct, and unspecified. And in ICD-11, we will see that these sub-specifiers have been removed. Now, ICD-11. So, as per ICD-11, a maladaptive reaction to an identifiable psychosocial stressor or multiple stressors that usually emerges within a month of the stressor. Now, in DSM-5, it was within 3 months of the stressor. The reaction to the stressor is characterized by preoccupation with the stressor or its consequences, including excessive worry, recurrent and distressing thoughts about the stressor, or constant rumination about its implications. Now, the symptoms are not better explained by any other mental disorder. This was similar to DSM-5. Once the stressor and its consequences have ended, the symptoms resolve within 6 months. The next criteria is that there is a failure to adapt to the stressor, resulting in significant impairment in personal, family, social, occupational, educational, or other important areas of functioning. If functioning is maintained, it is only through significant additional effort. Now, additional clinical features. Symptoms of preoccupation may worsen with reminders of the stressor, resulting in avoidance of stimuli, thoughts, feelings, or discussions associated with the stressor to prevent preoccupation or distress. Additional psychological symptoms of additional adjustment disorder may include depressive or anxiety symptoms such as impulsive externalizing symptoms, particularly increased tobacco, alcohol, or substance use. Symptoms of adjustment disorders usually abate when the stressor is removed, when sufficient support is provided, or when the affected person develops additional coping mechanisms or strategy. Now, symptoms that occur as a transient response and resolve within a few days do not typically warrant a diagnosis of adjustment disorder. In cases in which responses to traumatic events are considered normal, given the severity of stressor, acute stress reaction may be assigned. Now, what can be the developmental presentations? Now, in children, we see that the characteristic symptoms of preoccupation with the stressor or its consequences or constant rumination about the stressor are often not expressed directly, but they're rather manifested by the somatic symptoms. Children will come with somatic symptoms like stomach aches, headaches, or disruptive or oppositional behavior, hyperactivity, tantrums, concentration problems, irritability, increased clinginess. Other reactions to stressor include regression, bedwetting, and sleep disturbances. May be a manifestation of adjustment disorder if they are persistent. In adolescents, behavioral manifestation of adjustment disorder can include substance use and other various forms of acting out or risk taking. Because children and adolescents may not explicitly verbalize a connection between stressful event and their own symptoms and behavior, in making the diagnosis, it is important to consider a temporal relationship between the stressor and the onset of symptoms and the extent to which they constitute a change from prior functioning. Now, among older adults, preoccupation with somatic complaints is a common sign of distress which is related to the stressors. Older adults who suffer from adjustment disorder tend to express greater anxiety about their health, report significant demoralization, and often display persistent somatization of psychological symptoms. Now we'll go through the diagnostic criteria as per ICD-10. Now, as per ICD-10, it is similar to ICD-11. The onset of the stressor should be within 1 month of the occurrence of the stressful event or life change, and the duration of symptoms does not usually exceed 6 months, except in the case of prolonged depressive reaction. If the symptoms persist beyond this period, the diagnosis should be changed according to the clinical picture present. Normal bereavement reactions appropriate to the culture of the individual concerned and not usually exceeding 6 months in duration should not be recorded here, but by a code of, as in ICD-10, disappearance or death of a family member or stress not elsewhere classified. Grief reactions of any duration considered to be abnormal because of their form or content should be coded, and those that are still intense and last longer than 6 months as prolonged depressive reaction. Diagnosis depends on a careful evaluation of the relationship between form, content, and severity of symptoms, previous history and personality, stressful event, situation, or life crisis. The presence of this third factor should be clearly established, and there should be a strong, though perhaps presumptive evidence that the disorder would not have arisen without it. If the stressor is relatively minor, or if a temporal correlation cannot be demonstrated, the disorder should be classified elsewhere according to its presenting features. Now, as in DSM-5, there in ICD-10 also there are sub-specifiers which include brief depressive reaction, prolonged depressive reaction, mixed anxiety and depressive reaction, with predominant disturbance of conduct, with predominant disturbance of emotions, with mixed disturbance of emotions and conduct, and with other specified predominant symptoms. Now, this is a table. This is a summary of the diagnostic criteria of DSM-5 and ICD-11. So, in DSM-5 and ICD-11, we saw that in DSM-5, the onset of this emotional or behavioral symptoms should occur like within 3 months of the stressor, and in ICD-11, they should occur in 1 month of the stressor. This is the difference. Now, another difference is that in DSM-5, it is given that the symptoms do not represent normal bereavement, and in ICD-11, no such diagnostic criteria regarding bereavement is given. In DSM-5, the symptoms, it is said that the symptoms are classically significant and are marked by distress and impairment in social, occupational, or other domains of functioning, whereas in ICD-11, it is said that there should be a preoccupation to the stressor and there should be failure to adapt. Now, these were the differences. The similarities are that the symptoms do not last for more than 6 months after the stressor is resolved, which is same in both of these, and the disturbance does not meet the criteria of any other mental disorder is also same for both. Now, the differences were the ICD-11 mandates that symptoms must emerge within 1 month of the stressor, while the DSM-5 allows a more liberal onset window of 3 months. DSM-5 specifies that symptoms cannot represent normal and culturally appropriate bereavement, whereas this is not mentioned by the ICD-11. ICD-11 requires symptoms of preoccupation with the stressor and failure to adapt. DSM-5 does not give any guidance so as to what symptoms might constitute distress. ICD-11 has removed any reference to adjustment disorder subtypes, referencing a unifaceted approach to the unifaceted concept of adjustment disorder. Conversely, the DSM-5 delineates the disorder into a series of 6 subtypes. Now let us come to various scales which can be used in adjustment disorders, which include the Thomas Holm and Richard Rahe life stress inventory scale, presumptive stressful life event scale, and the adjustment disorder new module 20. Now coming to the first of all the Holmes and Rahe life stress inventory scale. So this is the scale. In this scale, we can see there are 43 adult life events given, and each life event is given a score. For example, death of the spouse is given the highest score of 100. Then we have divorce, marital separation, and so on. And the last score of 11 is given to minor violation of law. So what do we do here is we ask the patient that within the previous year, what are the stressors they have met, and then we add all then we do the sum of all these stressors. So mark down the point value of each of these life events that has happened to you during the previous year. Then add all of your points to calculate your final score. 150 points or less, a relatively low amount of life change and a low susceptibility to stress-induced health breakdown. 150 to 300 points, 50% chance of health breakdown in the next 2 years. And 300 points, 80% chance of health breakdown in the next 2 years, according to the Thomas Holmes and Richard Rahe statistically prediction model. Now, an Indian version of this scale was presumptive stressful life events scale. Now, this is a suitable scale of stressful life event experienced by the Indian population for 2 time cases here, for the last 1 year and for lifetime. It was calculated that individuals in our society are likely to experience an average of 2 stressful life events in the past 1 year and 10 events in a lifetime without suffering any adverse physical or psychological disturbance. The scale is simpler to administer to literate and illiterate subjects. Now the scale was further divided into desirable, undesirable, and ambiguous. Now this is the scale. It has total of 51 points. Now 51 life events. And similarly to the Thomas Rahe scale, it has also each of the life event is given a score. Now here, as we said that it is divided into 3 parts, undesirable, desirable, and ambiguous. So the first 32 life events was said to be undesirable, and next 10 to be desirable, and next 10 were called as ambiguous, which did not come either in desirable or undesirable. Now let us come to the very recent adjustment disorder new module scale. It has been developed for the ICD-11 diagnosis of adjustment disorder and is available as a self-report questionnaire. Now, the first, it has 2 sections, basically, the ADNM-20 scale. The first section asks the participants to select from a list of stressors that have been present over the past year. So, this is the first part of the scale. And in this scale, there is no scoring as of the life events as it was in the previous 2 scales. But here we just ask the individual to take whichever stress was met with him or her, and then out of these as well, which caused the most distress to the patient. And then the second section of this, which we'll see, comprises of 20 items. Okay, and then these are the 20 items basically which the patient is asked to take, and it has 4 frequency scales: never, rarely, sometimes, and often, and it is given a numbering of 0, 1, 2, 3, 4. Then on the basis of the scale, we do the total scoring, and the total is basically 80. And if the score is above 47.5 or 48, it was said, then that basically means that the individual is more predisposed to having a adjustment disorder in the future. So these were the scales. Now let us come to the differential diagnosis of the adjustment disorders. Now the differential diagnosis, as we saw in the diagnostic system as well, can be major depressive disorder, or with anxiety, the anxiety subspecifier, generalized anxiety disorder, or the disorder of conduct. It can be so severe that it would even appear as if there is a brief psychotic disorder. Or as in children, we saw that children present with more of somatic complaints. So somatic symptom disorder. In adolescents, they are more prone towards substance use. So substance related disorder, conduct disorder, whereas personalities like antisocial personality disorder and PTSD. Now let us come to the management of the adjustment disorder. So the management, basically, it can be non-pharmacological and pharmacological. So pharmacological management in adjustment disorders is supportive, and the main management is non-pharmacological. So non-pharmacological management is based on the understanding that this disorder develops from a psychological reaction to the stressor, and the stressor needs to be identified, described, and shared with the patient. Whereas the pharmacological management, despite of the fact that it does not reach a threshold, the adjustment disorders do not reach threshold level for any specific disorder, this can still be given as a supportive treatment. Now, the non-pharmacological interventions. The majority of therapeutic interventions to adjustment disorder have three broad components in common. First of all, psychological interventions should aim to enable the individual to reduce or remove the stressor. For example, to reduce the stressor. The stressor, if, for example, is unemployment, it can be alleviated if the patient finds a new job, or if we have to remove the stressor. Now, to reduce the stressor, for example, any person is suffering from a chronic illness, for example, cancer, then it can be reduced by providing more social support to the patient. Now, the next is interventions try to enhance the coping abilities with the stressor and maximize adaptation. Basically, we focus on the negative thoughts of the patient are replaced by more of functioning thoughts. Third, symptom reduction and behavioral change is another important goal to reduce the stress and improve functioning in the long run. So this is a step care approach for adjustment disorders, the psychological intervention. So we have step 1, 2, 3, and 4. So in this step 1, we see there is watchful waiting or active monitoring. Then step 2 is low intensive psychological interventions. We'll see further like bibliotherapy and e-mental health interventions. Step 3 and step 4 includes psychotherapies, but step 3 is outpatient care and step 4 is inpatient care. So step 1. Now, given the step 1 was watchful waiting and active monitoring. Now, given the transient nature of adjustment disorders with symptoms defined to dissolve after 6 months, once the stressor or its consequences have terminated, watchful waiting should be sufficient for people with adjustment disorder. Knowing, however, about the complexity of course of mental disorders, the risk of chronicity and progression once symptoms are present, as well as the fact that stressors and their consequences might not terminate completely, the most logical indication of just watching until symptoms resolve may fall short and need further steps at hand. Now, the second step was low intensive psychological interventions. Now, the word low intensive here means that the intervention basically can be given by a less trained professional, for example, a junior medical doctor, or less wages for a therapist, and they can be provided by a less specialist health worker, and less resources are required. That is the meaning of low intensive here. So it includes, for example, the first of all, bibliotherapy or self-help. Now, self-help manual, basically it is based on the behavioral cognitive therapy. Now, this manual, it integrates a variety of approaches validated for treatments in PTSD, anxiety, depression. Now, the manual consists of 3 parts. The first 2 parts are primarily psychoeducational, and they contain a screening for adjustment disorder and a checklist for evaluating whether a face-to-face interaction with a therapist is needed. Now, part 3 constitutes the main body of the manual and is organized into 4 chapters describing various CBT exercises: sense of self, understanding one's personal stress response, coping, learning strategies for the management of ruminations and anxiety, activation, carrying out exercises that evoke positive emotions and activate personal resources, and relaxation, understanding the importance of experiencing a balance between activity and relaxation. Or support groups, mindfulness, meditation and relaxation, and e-mental health interventions. That is an internet-based self-help intervention known as brief adjustment disorder interventions for the treatment of ICD-11 adjustment disorder. In the self-help trial, completed analysis revealed that brief adjustment disorder intervention reduced ICD-11 adjustment disorder symptoms and increased psychological well-being for those participants who used the intervention at least once in 30 days. Now, psychotherapy, including the cognitive behavioral therapy, psychodynamic psychotherapies, and interpersonal psychotherapy. This is the 3rd step. And the 4th step is basically these interventions in an inpatient care setup. Now, pharmacotherapy, which it is basically used as a supportive treatment. Psychotropic medications have been used in medically ill, terminally ill, and in patients who have been refractive to verbal therapies. Antidepressant therapy, if there is no benefit from 3 months of psychotherapy or other supportive measures. Psychotherapy combined with benzodiazepines may be helpful, especially for patients with severe life stresses and a significant anxious component. Now, tricyclic antidepressants were recommended in place of benzodiazepines in patients with recurrent or past heavy alcohol use because of greater risk of dependence in these patients. These are my references. Thank you. E-mental health, basically, this is a internet-based website. Study I read it in a research article. There was a brief intervention, BADI, brief intervention, adjustment disorder intervention, and it was seen. This is a self-help trial for, and it basically increased the psychological well-being.
Will to understand it. As well as that this neurobiology of because it is actually neurobiology of stress correlates with that stress in the brain scan. Increase immunity, increase risk taking behavior. Okay, so stress disorder is associated with increased risk of this. It is not really this chart starting from and it is not going to separate marks that and second interaction between the ability of and the stress that leads to the that's the stressful life events in the focus. What is the need for many times you write stressful situation, patients coming, they somebody having a problem and you need to prescribe medicine, insomnia, anxiety, and then you need a diagnostic criteria to for the insurance in the work. And so you need a diagnostic criteria. It is mentioned in the first slide only. It is a base data point. So you can't put it into clinically if you want. So there it is. All of that is wide variety in the it's a different industry. A lot of people going to that cannot be what is what people
because sir, the diagnostic criteria is given that if after the removal of stressor, then within 6 months the symptoms do not resolve, then we call it adjustment. So if the stressor is not removable, so will it still be
You got the answer to the question. So your criteria is, what is your take on the 6 months criteria?
Mm.
Can there be permanent adjustment? That is the question. So what is your take on the 6 months criteria? So I think DSM-5 is accurately actually put it. I think rather than other two diagnosis systems, that it should once the stressor or its consequences have terminated, the symptoms should not be more than additional 6 months. So if the stressor is continuous, so someone whose shop has caught fire, that the stressor doesn't end there. The financial implications of it, if they're persisting, the stressor is persisting. Till the stressor is unaccountable, and then from there 6 months, it should have. So if someone from a rural area joins a school in an urban area, English medium, till the stressor is built up, you'll actually call it. You will not actually put into a duration thing. Now this 1 month or 3 months is within the stressor time frame. The symptom should be in the stressor onset. The symptom should be so that we call it that we temporarily attach symptomatology to the stressor onset. So तभी हम उसको कहेंगे कि उस चीज से adjustment का problem. But जो 6 months वाला है, that is actually after the consequences. So that is the whole concept of it. So it can actually last for years. If it is the symptom of recurrent abuse by parents or by spouse, recurrent, that is also there. And it is about adaptability. So it's more of if you're not able to adapt, you're going into diagnosis of adjustment disorders, but adjustment disorders are subsyndromal diagnosis. So I think with time, person will move into one or the other syndrome, either anxiety disorder or depressive disorder, or even a psychotic disorder, severe active. So that is why adjustment disorders continue to be important and critical. We do find a lot of patients with adjustment disorder. But patient admitting here with adjustment disorder will be little because it's in subsyndrome diagnosis kind. What is your answer? What is your answer? That. What is your answer to that? And if there are both the things, then can there be comorbidity and both that as comorbidity? Okay. So these are two disorders different states. Adjustment disorder is different. Depressive disorder is different. It's not that adjustment disorder is something common depression. You have brief depressive disorder type of criteria for that. Other depressive disorder. Yes. That's an ICD. DSM में नहीं है. And very important criteria in ICD-10 was conduct.
Yes, sir.
अच्छा एक मिनट वो आप लिखा ये वाला पॉइंट सी पढ़ना जरा सर. So prior history of depression, you are vulnerable for subsequent depression, and maybe a patient has come maybe after 5 days or 6 days after onset of an episode, specific trigger by a stress. We can conceptualize at that point either it can be an adjustment disorder itself or it is a recurrent depression coming. But because it is not fulfilling the criteria, you can move it with time will be more clear.
but it should not. But if it is an isolated depressive episode, it is already fulfilled the criteria. And we are explaining in the current circumstances. One had a depressive episode 2 years back, uses breaks into depression, to syndrome of depression. And you can probably diagnose the patient not with a discipline.
See, diagnosis per se we are making for two purposes. One is for management. Okay. Whether you are if you're different diagnosis, it alters the management. It is for research purpose. You want you're like if you want to take say some patient for a trial of depression. Okay, and there you're thinking that there is some significant thing like homogeneity of adjustment disorder, whether that will affect your outcome. Okay, so that you have to see. Otherwise, for management part, if you think that you have to, apart from managing depression, you have to go for managing the stressor. So that also you have to see. But mostly, yes, that is true for adjustment disorder. You have any comment, Sarthak, about adjustment disorder? Have you seen any patient of adjustment disorder that you can tell us significant?
Go to Mooms and Rai.
Yes.
Okay. What was the specific that? That the symptoms.
No. Yes, sir. And so when she first presented to us, the symptoms, the conduct was so severe, we thought that it was a psychotic disorder. Then we came up that she had some personality issues. Then we came to the final diagnosis that it is adjustment disorder.
JR1, JR2, I think if you have like topic, you must have seen some patients who can come with a small short summary of the case as a comment. Yeah, that I saw this patient. Have you been able to see any adjustment disorder in this few months that you've been there? No, you don't remember. You can come prepared with that.
Frequent scenarios of adjustment is post marriage. Because you can see marriage is 50, scale 50. Marriage per se is getting married. It's a very stressful circumstance. And I think post marriage also, a lot of females who come brought by husband once they go into little aggressive or develop some dissociative episodes. Till then they'll ignore the soft mood symptoms. You ignore till someone dissociates or as goes into content kind of a picture. But mostly in adjustment disorders, good psychotherapy generally resolving the illness burden. Until someone is predisposed to depression and pharmacotherapy steps. But in any case, major depression, mild varieties, you only with the same. Your comment? I think these two skills are very important. Of life stress scale and presumptive light scale by Sukhbir Singh ji, a very prominent psychiatrist. I think he went to Punjab. So this is an Indian scale, so this is very frequently asked in exams. So I think must remember. And this can be a short note or even a long note. And it's a frequent viable question. So I think very important. Diagnostic criteria are the guidelines which guide us, but they are not rule of law. So you need to develop a concept the patient has had a change of a region, a change of a language, and is beginning to solve the questions of therapy. And then we can certainly diagnose the patient and subsequently put a reassurance also at times. Can be beneficial. I think Dr. Asta, as usual, she is very critical. She will even visit a model used by APA to treat these patients. And I think the position of ICD-11 not considering bereavement, but you see the model which she is presented, a scale which she is presented, which is based on ICD-11. Go to the scale.
Yes,
So there, if they consider death of loved one, illness of loved one, these points. So I think ICD-11 also considers bereavement reactions within the adjustment disorder. I think will be.
Can you please go to the next slide? Yes. So adjustment disorders, I think they're very easy diagnosis to make, but they actually are very difficult diagnosis. Okay, every stressful event will cause some behavioral and emotional changes in a common individual. So what we have to do is first we don't overdiagnose it. That we see we are in a hurry to diagnose, we see a clear stressful event and a emotional picture, and we diagnose the adjustment disorder. Sometimes you have to think deeper. So first slide. So you have to, whenever you see a stress, you have to see all this. You have to rule out all the stress related disorders, number one. Number two, we know that stress can precipitate any disorder. Okay. If you're considering adjustment disorder, you should thoroughly work up that it is not a prodrome or exacerbation of any other presentation. GAD patient may present with exacerbation. OCD, they are very, they hide their symptoms unless and until you directly ask. Okay. Depression, they may think that depressed mood is not a complaint to think about. So even if you clearly see that there is a adjustment disorder, you have to rule out all the other disorders before you diagnose adjustment disorder. Third thing is that adjustment disorder is heterogeneous. So it can mark from like somebody coming with a loss of business. Okay. So one person may have only insomnia, anxiety, it may do well with one, you can say medication. On the other hand, suicidal behavior just after stressful event. That is also loss of phase, business, and in our context, if you don't find in this list of stressor is failure in exam. That is very common stressful event here that just after failure of exam, a person develops symptoms, suicidal behavior. So depending upon the presentation, we have to seriously take into account. Okay. So whenever there is, you think of adjustment disorder, please do assess for suicidal behavior and you should take actions accordingly. Just do not diagnose it adjustment behavior disorder and because usually we think of adjustment disorder in our like normal we have attitude of a little relaxed nature that okay, adjustment disorder is not, but in certain cases it can be because we see impulsivity, suicidal behavior just after. So that you should always. These are my points regarding the topic. And as far as presentation goes, Dr. Asta came to me in time. She discussed with me the topic, how to approach it, and he has covered all the things that were asked of us, and respect. So very good presentation.
So one more thing, just to close it off, that stressor now is a very subjective issue. In personal context, knowing the culture, it can be very tricky. When there is a minimization, person might minimize a lot of things and at the same time magnify. So at first instance of your contact with the patient, you won't know everything about the patient can be very difficult. So you need to basically follow the patient and to be more clear. Consequences or intensity.
Yes, I think that we always say that we have to manage a disorder on case-to-case basis, but I think that it is like for adjustment disorder, it is very, because in some cases it is very severe, some cases, and in some cases clearly we can see it's form of something. So in other guidelines are more clear, we know how to do psychosis and more to do what in adjustment disorder, we have to really go according to the patient. And so, what's